Welcome to CBHN's Health for Life series on prediabetes and prevention. My name is Amber Busby. I'm the Associate Program Manager at the California Black Health Network. Today, we are here for session 7, the final session of our 7-part series, Control the Controllable. We have the pleasure of hearing from Dr. Karen Beard, who I will introduce momentarily. Dr. Beard will lead us in a discussion on nicotine dependence and prediabetes and strategies for tobacco cessation. While this webinar is designed to be interactive throughout this session, you will be muted. We encourage you to use the raise hand feature for comments or questions and/or to put any questions in the Q&A box, which you can find at the bottom of your Zoom screen. Before I introduce our speaker, I want to share a little bit about CBHN in case any attendees are unfamiliar with our organization. The California Black Health Network's vision is a California where every African American and Black immigrant has the opportunity to live long, healthy lives, free from violence, racism, and health inequities, regardless of their education, socioeconomic class, orientation, gender identity, housing or immigration status, and have access to high quality and equitable primary and behavioral health care. We do this every day through our outreach, education, policy, and advocacy work. At this time, I am pleased to introduce Dr. Karen J. Beard, who is a certified tobacco treatment specialist. She earned her tobacco treatment specialist certification from Florida State University. She facilitates free and proud living well without nicotine, a culturally appropriate and evidence-based tobacco cessation program for African Americans. Dr. Beard is a member of the African American Tobacco Control Leadership Council and national spokesperson for Amplify, the African American statewide coordinating center whose mission is to provide culturally relevant expert support and tailored assistance to tobacco control programs, non-traditional partners, and the greater community. Dr. Beard is a co-facilitator of the Tobacco Partners Research Group, a national organization for tobacco researchers. She was the principal investigator in the California Black Women's Health Project community-based research project, regulating menthol cigarettes, African Americans' attitudes toward a flavor ban. Dr. Beard is a counseling psychologist, disability and rehabilitation consultant, retired, and she has 30 years experience providing counseling, social and human services case management. At this time, I'm pleased to turn it over to Dr. Beard. Thank you so much for being with us today.
Thank you, Amber, for that wonderful introduction, and I'm so happy to be here this afternoon. I just thank you all for allowing me to be here with you to talk about something that means so much to me. In one moment, I will share my screen. Okay. So as Amber has indicated, I am with Amplify. Amplify is the African American Statewide Coordinating Center. And this afternoon, what I'd like to do is talk about pre-diabetes, diabetes, and tobacco cessation, especially as it relates to our African American brothers and sisters. And so I'm going to begin by telling you a little bit about my story. I'll give you some background on AATCLC, the African American Tobacco Control Leadership Council. And I always like to say, just to be able to say that without flubbing it up, I think I should get some kind of prize. And then I'll talk about Amplify. And then I want to introduce you to the Amplify family. I'll talk about nicotine dependence from the perspective of diabetes and pre-diabetes, and then we'll have Q&A. A little bit about me. You've heard about my educational background, etc. But what most people don't know about me, in addition to being a project manager of a cessation capacity building project, spending all those years in disability and rehabilitation, helping people restart their lives after a work related accident or some kind of medical condition. Um, I also had my husband of 23 years who smoked Newport cigarettes. Um, he started smoking around age 15, and I would say, was a dedicated smoker. A person who smokes. I try not to call people smokers. I like to use the language people who smoke. And so he smoked Newports. And, in the beginning of our marriage, it didn't bother me. But then I forget what age, he had lung cancer, and they had to remove one third of his lung. I forget what side. And then later on, I think it was about 3 or 4 years later, of course, he continued to smoke. So he had a half of the other lung removed, and I just couldn't figure out, why in the world would he continue to smoke after having, gone through all of that. And so I did everything I thought was the right thing to help him quit. But in hindsight, after his death on November 25th, 2013, I realized that although I had a counseling background, I defaulted to doing the wifey thing, which was run my mouth. I tried to shame him, guilt him. Um, don't you want to see the grandkids grow up? How could you continue to smoke? That kind of thing. And so I like to say, while I am very compassionate today about helping people quit smoking, when I reflect back on my experience with my husband, um, I wasn't that person then. And I spent a lot of time thinking, just why couldn't I help him? Why did I say and do the things that I did? And what I learned from that experience was, although I knew counseling, I knew disability and rehabilitation, I had helped so many people, I didn't know tobacco. And so I decided to go to Florida State University and become certified as a tobacco treatment specialist. That was in 2014. And I have been doing this work since 2014. And I share that with you all because I want you to know that I'm not here with you this afternoon because of any of my degrees or anything. I like to say that this work chose me because after I lost my husband of 23 years and felt like I had done um, all of the wrong things, I don't have guilt around it. I just knew that I didn't do the right thing. Um, my being here with you all and the work that I do is so that perhaps I can save another family or support another family into helping their loved one. And so again, I'd like to say, wow, that's who I am today. Very compassionate about tobacco work. It wasn't always like that. And so when moved to California in 2016, I'm sorry, 15, I was very fortunate to um, meet an organization called the African American Tobacco Control Leadership Council, AATCLC. And the council was formed in 2008. And the purpose of the council is to educate the African American community about tobacco use and cessation. And AATCL C partners with other community stakeholders and public health agencies to inform and affect the direction of tobacco control policies, practices, and priorities. You may have heard about the FDA filing suit. I'm sorry, a suit being filed against the FDA to make them do what President Obama had asked them to do in 2009, and that is to take menthol cigarettes off the market. Well, they drug their feet, and so last year, I believe it was in April, AATCLC, along with other community organizations and organizations like the American Medical Association, the Public Health Law Firm, Law Center, I'm sorry, came together and filed suit. And so now the FDA is in what they call rulemaking. Um, and so it'll be another probably a year or two before we actually see, all of the products off the market and all of the rules in place. But what you see pictured before you are kind of like the originators or, the founders of AATC LC. And so I mentioned that I'm with Amplify. So if you think of AATC LC as being about tobacco control, Amplify, we are about, and what I mean by tobacco control, we want to take the products off the market. We don't want them sold. So if you look at Amplify from another perspective, we're all about decreasing the demand for the project. The products. We believe that it takes both. We got to take the products off the market, but we also have to decrease the demand by helping people give up nicotine and tobacco products. And I mentioned nicotine because you may hear me talk about cigarettes or you may hear me mention tobacco, but because vaping is so popular now, I like to use the word nicotine because then that brings in the vaping as well. So Amplify, we're all about physical, mental, and spiritual wellness. So we have a holistic approach to helping people quit smoking. So this is my family. I work with these people, Kara Magruder, as you can see, program director, Yolande Burris, Ernesta Wright, Reverend Kelvin Sauls, and Dr. Robin Battle. And I don't use that word fam lightly. We are a family. We're very tight knit. And so, again, I'm very appreciative to have come to California and met all these wonderful people doing this important work. Some of our regional grantee partners, meaning those people that we work with to in the region, although we're statewide, these are just a sample of some of the organizations that we work with to really end the tobacco's game. The goal is to by 2035, our goal is to have tobacco or nicotine products to be history. So you can see the SOUL organization there, which stands for Saving Our Legacy, Keeping Our Lungs Safe. We have a Youth Leadership Institute. And one of the things that I like about our approach to working with regional partners, it's that we do fun things for young people who embrace this work. For instance, we have spoken word contest. Young people that age, they don't want to sit in a seminar, a webinar like this, and so we give them their own platform to be creative. So just a little bit about the technical assistance that Amplify provides. As you can see from the slide, that we provide tobacco prevention navigation. We provide custom assistance and moral support. And what we mean by custom is that we don't have a standard approach. We go into, if an organization contacts us, we take a look at that organization's needs. or desires, and then we tailor something for that organization. We focus on cessation, quitting, and support, not only for the person who smokes, but also for that person's family, as well as the professionals who serve them. We have programs that we engage in terms of, getting the Black community on board, capacity building, leadership development, excuse me, and we offer trainings, workshops, and webinars. On this slide, you see just some of the flyers from things that trainings that we've done in the past, like Tobacco 101. We've addressed predatory marketing by the tobacco industry. Their philosophy is profit over people, and so we do training around that. Community engagement, tobacco related diseases, and then keynote at different conferences. So again, this is just a slide showing that, people who have attended our trainings find them useful, and they find the data that we present to be very helpful and telling. Amplify offers free resources to the community. These are some of our resources. We have toolkits, and as you can see from the slide, you can download them from www.amplify.love. We participate in No Menthol Sunday. Now, in my slides up, I can't see you all, but otherwise I'd have you raise your hand to indicate whether you've, excuse me, ever participated in a No Menthol Sunday um, uh, uh, day. I think it's the fourth Sunday in May. And in some areas of the country, it's no longer a day, it's like a week, or, you can do pretty much whatever you want to do. And what we ask the African American community to do on that day is not to purchase or smoke menthol cigarettes. We also have what we call love cards. We like to say that we love on our people who smoke that are struggling to give up nicotine. We don't believe in approach where, you see all those horrible um, commercials with people with half their faces missing. Obviously they've had some type of cancer or whatever. So we take a different approach. We want to make it positive, attractive. And so as you can see from the slide, we have Dear Brother, We Got You, Let's Kick It Together. And we have one that says Dear Sister. We have the prayer cards, and we have fact sheets. And these are all free resources. So if you or your organization would like to have some of these to pass out to, for instance, if you are a faith-based organization, you can get our prayer cards. If you are having a tabling event, you like to have some of our cards, just reach out and at amplify.love. You can contact me and we'll see about getting them to you. Just more of what we do, social media campaigns during Black History Month, No Menthol Sunday, I mentioned that. We participate in Great American Smokeout and Black Maternal Health Week. We also have what we call community engagement awards that goes out to, organizations in the community. Right now, well, I think I learned today that there's a waiting list, but what the community engagement awards are, they're just small grants. I think the maximum is $3,500 for you to, um, meaning your organization or an individual to do something in the community. And as way of an example, we had he's called That Yoga Dude. And so, a lot of people smoke because they're stressed. And so this young man, James Woods, came up with teaching people yoga. and he does it outside, he does it virtually. We have another young man that's doing something very unique in terms of gardening. And so that's what our community engagement awards allows individuals or community-based organizations to do, to come up with a creative way to engage our people in ways to release the stress and also embrace giving up nicotine. Again, we do technical assistance. I'm not going to go over that slide. And then we have a program Amped Up, which is a paid internship program. We realize that some of us are aging out of this work. And so it's very important that we train others to take over. So we do have a paid internship where we talk about leadership, building community, and all of that. All right, so I talked about that. This is Amped Up again, some of my fam. So I won't go over that. And so nicotine dependence, diabetes, and pre-diabetes. Let's talk about that a little bit. So I'd like to pose this question to you. What does nicotine dependence and type 2 diabetes have in common? I don't know if you all can respond. Can you? I'm sure you can hear me, but who would like to answer that question? What does nicotine dependence and type 2 diabetes have in common?
I don't know that our guest can unmute themselves.
Oh, okay. I see. Oh, I'm
We do
sorry.
have
Okay,
someone
Amber.
adding into the chat, though. Thank you so much. Both are high among African Americans.
That's true, but I'm looking for something else. Okay. Well, the answer is both nicotine dependence and type 2 diabetes are chronic relapsing disorders. And the reason I'm making a point um, or to about this is because while most of us accept type 2 diabetes as being a chronic relapsing disorder, very few people look at nicotine dependence or tobacco use as being a chronic relapsing condition. But it is, according to the World Health Organization, it is according to the Centers for Disease Control. And it's important to raise this issue around diabetes, prediabetes, and nicotine dependence because if we don't recognize nicotine dependence as a chronic relapsing condition, then people who have diabetes or pre-diabetes cannot get the services and the products that they need covered in a way that they need to be covered. We tend to treat nicotine dependence like an acute disorder. And what I mean by that is, you get a headache, you take a aspirin, and you feel better. So what we say to people that smoke is, just stop smoking, stop buying them. Why don't you quit smoking, as if, it's something acute, but it is a chronic relapsing condition, and it should be treated on the same level with diabetes and pre-diabetes. So I think another reason why when we talk about tobacco cessation and nicotine dependence, that it's not looked it's not looked at as a chronic relapsing condition, but it's also not looked at as a psychoactive substance. I can't tell you for sure what people think about nicotine, but it is a psychoactive substance. Um, what it does is it affects the neurotransmitters in the brain. For example, when people smoke, it only takes 10 seconds for the nicotine, which is the addicting substance in tobacco, to get at the most 10 seconds. 10 seconds to get to the brain. And then what that does is it triggers the brain to release dopamine. And dopamine is that feel good transmitter, or it will release serotonin. And serotonin is that transmitter that helps us become calm and helps us sleep at, night or whatever, it calms us down. And so, again, I don't know how say the lay public thinks about nicotine, but it is a psychoactive substance. And as it relates to diabetes and prediabetes, it can cause insulin resistance. Tobacco, the average cigarette has about 10,000 chemicals in them, and 40 of them are carcinogens. And nicotine nicotine affects the brain, but the chemicals, and we call it tar, in the cigarettes, it affects every organ in the body. There is no organ in the body that is not affected by the tar in cigarettes. And the tar is produced by the burning of the tobacco. And so we call it, combustible product. It's a combustible product. And so it produces tar. And just let me say, some people think that vaping is safer than smoking cigarettes because, yes, when you vape, you're not getting the tar, you're just getting the nicotine. But the bottom line is you're still introducing heat into your lungs, which can cause inflammation. So I get that question a lot. Dr. Beard, is vaping safer than smoking cigarettes? Yes and no is my answer. You don't get the tar, but you still introduce heat into your lungs. So when you think about nicotine as a psychoactive substance, it's a stimulant like caffeine, amphetamines, and cocaine. And it seems that we're kind of clear when it comes to caffeine, amphetamines, and cocaine, but it's a hard sell to get people to see nicotine the same way we do caffeine and amphetamines and cocaine. But nicotine is a stimulant. That's why, so I don't know if you've ever heard people say if they're tired or if they're stressed, they smoke a cigarette and then they instantly, get a burst of energy. And the other thing about nicotine is it can be a depressant. If you're hyped up, you're stressed or whatever, you can smoke a cigarette and it brings you down. Or it can chill you out, like some people will drink to just get in a different mind state of feeling, all is well. And so, again, nicotine is a psychoactive substance that also has the capacity or ability, I should say, to calm you down, become a depressant for you. It's also like an opioid, heroin, morphine, or fentanyl. But again, we don't think of it like that. It can be a hallucinogen, um, and like LSD. And as you can see, also cannabis. And that's alarming because many people will combine, marijuana, cannabis with nicotine. And so, we spent the past 3 years talking about, I think it's been 3 years since COVID, um, and we say it's a pandemic. Well, when you talk about nicotine dependence and the patterns of use, especially in our African American community, is really a syndemic. A syndemic is where you have, more than two. Um, uh, Things coming together and acting in a more powerful way. And so I like to tell people that I work with, nicotine, menthol, and caffeine, because people who smoke often drink coffee while they're smoking, so they're getting the caffeine, they're getting the nicotine, and if they happen to be smoking a menthol cigarette, now they have the menthol. So that is a syndemic that we are struggling with in our community. So let's talk a little bit about type 2 diabetes and passive smoke. Most times when we're talking about tobacco use, we're talking about the person who's actually doing the smoking. But there's another risk, especially for type 2 diabetes, that we need to be aware of, and that's passive smoke. Now, what we mean by passive smoke, you're not the person doing the smoking, but somehow you're in the uh, within the environment of the person who's doing the smoking, or had been in the person has smoked in the environment you walk through. I just had that happen in my neighborhood, which I was shocked. I said, somebody's been smoking out here. Because when I came through, I could smell it. So that's passive smoke. Sometimes we call it side stream smoke. I mean, it's not being inhaled this way, it's out in the environment. And passive smoking or side stream smoking is a risk for type 2 diabetes. And so we also know that environmental tobacco smoke and nicotine can cause insulin resistance. Again, you don't have to be actively smoking. You could just be, a lot of times you might hear about secondhand smoke. But there's also third hand smoke. I don't know if you've heard about that. That's where someone has smoked in the area, and we call it softscapes, like your rugs, um, your drapes, your couch, if it's fabric. The um, the chemicals from the smoke can get into those things, and then here you come, you sit on the couch, you open your drapes or whatever, and so although you didn't smoke the cigarette yourself, you've been exposed to it. And again, nicotine can cause insulin resistance. um, Research shows that environmental smoke contains many toxic components, as much as 5 times more carbon monoxide, and then 3 times more cigarette tar. So this is not, something that we should take lightly when I talk about passive smoke. Passive smoke can be just as toxic. I've known people who never smoked in their lives, but they died from tobacco related diseases because maybe they had a spouse who smoked, or a friend, or they were in the environment. Now, I'm not saying that I want, if you have any friends that smoke or whatever, don't throw your friends out. Just try to support them in giving up the nicotine. And again, passive smoking is a risk for type 2 diabetes. So, what can we do to help people stop smoking? One of the things that we can do is show compassion. As I learned from my experience with my husband, all that nagging, and, I cussed, I fussed, I cried, I tried to shame and guilt him. That's not what people who smoke need. No one begins smoking because they want to die. We talk a lot about health, and it will kill you. But along the way, there are other things that uh, smoking can do. It can. There's some research that shows that divorces are going up because you have one spouse or a mate who smokes and the other one doesn't, and so there's some friction in the relationship around smoking. But we believe, meaning Amplify, my approach to helping people to stop smoking is to show compassion. You might not have a smoking thing, you might not be challenged with nicotine, but we all have something. For me, it's cheesecake. I know I shouldn't eat a lot of cheesecake, but it's a conspiracy. I believe the grocery stores, they put that cheesecake, the bakery is always right up front because when you walk in there, it's like, especially if they bake some stores, they bake their own bread and all of that, it just kind of pulls you. And so what I try to do is put myself in that person's place, and so that I can show compassion. Um, in hindsight, I wish that I had done that with my husband. And what do I mean by show compassion? Instead of telling people what not to do or you should stop smoking, I wish that I had asked more questions. What can I do to help you stop smoking or support you in stop smoking? What is it about smoking that you like? Or, what can we talk about and maybe do that would give you that same feeling? So, instead of making statements, showing compassion to me means putting yourself in that person's place and maybe asking more questions than talking. Because, grown folks don't like to be told what to do. We call it psychological reactance. And well, some teenagers do. If you tell them what to do, they're not going to do it just because you told them to do it. And so you have to find the right way to support the person. And another thing that I'd like to suggest that we do to help people stop smoking is to normalize or just accept that it's going to take multiple attempts to give up nicotine or to stop using tobacco because it's a chronic relapsing condition. We don't say to people with diabetes, you only get two times to come to the doctor. After that, if you don't, manage your diabetes, we're done with you, that type of thing. So there's nothing wrong if a person has to take, um, it takes longer. So we use an individualized approach. We don't, I don't amplify philosophy. I don't ask people to give up smoking in 2 weeks because maybe it will take longer for that person because maybe they have different challenges than another person. For instance, if you live with a person that smoke, I have a couple right now. The husband wants to quit, but the wife doesn't, and so it's a challenge for him because he smells the smoke on her hands, her clothes, her hair, and whatnot, he says. And so then it just triggers him to want to quit. So my point is, we can't demand that people quit in a certain period of time because everybody has different challenges, and we should accept that it's normal to have to make multiple attempts to quit. And I also believe that what we can do to help people quit is to um, let's take the tobacco services to the people. Ordinarily, we expect our physicians to ask at every visit that whether you smoke or not. If you've ever, probably you've been asked that, and that's great and that's fine. But we also know that many of our people don't go to the doctor as they should for whatever reason. And so instead of just depending on a physician to be kind of like that gatekeeper to, identify who's smoking, let's take the um, services to the people. And so, what we're doing in LA County is we're training community based organizations how to offer these services. Along with tobacco cessation, we also incorporate chronic diseases because the truth of the matter is a lot of people that we see smoke, that are people who smoke, they also have chronic conditions like diabetes, high blood pressure. And so we don't do in depth, but we show the relationship between tobacco cessation and, chronic disorders. And one of the biggest challenges for people who smoke is to be able to, most people can quit because honestly, most people quit every night. Very, very, very few people wake up to smoke. Now, they may wake up and go to the bathroom and decide to have a smoke, but a cigarette, but they don't wake up specifically to smoke. So the quitting is not the problem; it's remaining quit. And one of the challenges for people who smoke is that, how do I integrate all of these new strategies into my life? I'm already consumed with, I've got to manage my diabetes, which means doctor's appointments, eating certain foods, and what happens if I live in a food desert. And so, and trying to make all that work, I call it kind of like the IKEA approach where, we give people all this information and say, okay, now go out and, put your life together, make it work. But if you're like me, I can't put anything together. So I would box all that stuff up and take it back to IKEA. So we have to do better than that. We have to help people integrate these new strategies into their lives. Um, and so, nope, oh, sorry about that. So I'm told we have some questions in the chat. And so what I'll do is I'll start right here and answer any questions that you may have.
Thank you for that, Dr. Beard. We do have a couple of questions. One question is, if you could just reiterate, what was the commonality between diabetes and tobacco use? Wanting to verify, was that chronic relapse
It's a
risk?
chronic relapsing, both are chronic relapsing conditions.
Thank you. That's one question that we had in the chat, and then we do have a couple in the Q&A.
Okay.
This participant is wondering if you can clarify that whether you're saying if a person who smokes has type 2 diabetes, then the medical professional should treat both the diabetes and the nicotine dependency at the same time.
I believe they should. And what happens now is, for example, if you when you go to your doctor, your PCP, it's discovered through lab work that you have diabetes, they don't say, well, do you want me to treat your diabetes? They start right away talking about what you need to do now, your treatment plan, the medications, if it requires a referral for whatever reason. In other words, they start to um, put into motion those things that need to be done to manage your diabetes. But now, if you go in and they ask that question, do you smoke? And you say yes, it's a different approach. Most people have to say to their doctor, well, what can I do? Or what should I be doing? So right now we're working on applying for a grant to see if opt out instead of opt in is a better approach. And what I mean by opt out is if you're a physician, your patient says, I smoke, you would follow the same kind of protocol you follow with diabetes. You would just assume this person wants help. And so I'm going to make referrals for you. These are the nicotine replacement therapy products that you could consider. Whereas today it's more you have to opt in, you have to say to the doctor, oh, I want help with this. And I hope I'm making myself clear. So my opinion is if someone smokes and they have diabetes, you want to treat or you want to address both because the nicotine affects insulin resistance. It can cause it or aggravate it. And so it would be futile to treat one and not the other, in my opinion. So you would treat both.
Thank you for that. The next question that we have is, since both are psychoactive drugs, does THC and nicotine have the same chemical effect on the brain?
Um, was that THC?
Yes, and
Uh-huh.
nicotine.
Both affects the brain, but nicotine affects the brain in terms of your neurotransmitters. And I believe I'm not that familiar with THC, but psychoactive substances in general affects the brain. Um, and how nicotine affects the brain is that, for instance, when the dopamine, if you're not feeling good or whatever, of course, and you smoke a cigarette, then that makes you feel better. Um, because the brain will produce dopamine if you're tired or whatever. If you uh, Some people use nicotine. Nicotine is an appetite suppressant. So if you want to lose weight, some people will smoke a cigarette um, to lose weight. Now, the problem with nicotine and the neurotransmitters is that the brain is very smart, and I mean in terms of if the nicotine is triggering the brain to, say, produce dopamine, it is not going to overdose itself by continuing to, um, I should say, nicotine mimics dopamine. So, what the brain will do is at some point it will stop producing dopamine, and it will rely on the nicotine to trigger it to produce it. So the brain will stop. It'll rely on the nicotine to trigger it to produce it. So when people stop smoking, now the nicotine is not triggering the brain. The brain has become dependent on the nicotine. So you might hear people who stop smoking complain about feeling depressed or down or can't sleep, insomnia, because now the same thing happens with serotonin. The brain is not going to produce it. The nicotine mimics it and forces the brain to produce it. But when you stop, it takes a while, and it's not long. It takes between 2 and 4 weeks for the brain to naturally start up producing it without being triggered by the nicotine. So I like to tell the people who smoke, if you could just get through those 2 to 4 weeks when their body is readjusting to not having the nicotine, the brain is readjusting. Um, it would be easy to give up um, smoking. But what I find it, and so I find that it is more challenging psychologically than from a physiological standpoint to stop smoking. So the body and the brain will readjust 2 to 4 weeks. Um, the lungs will have cleared out and all of that. But people who psychologically depend on nicotine to manage negative states like stress, depression, um, many people believe that when they smoke, that it helps their stress. But, we believe that if you think about the act of smoking, what you do, you inhale, take a drag, I guess you call it, and then you exhale, you blow the smoke out. That's the same way we practice. Now I'm having a brain block. Um, inhaling, exhaling, stress reduction. What do we do? Inhale, you can hold, then you let it out. So it may not be so much that the cigarette is helping you with the stress, but if you believe that, psychologically, you believe that, that's harder for some people to give up than actually the body clearing itself of the nicotine. I hope that makes sense. And I so wish that, we could have a dialogue. I thought we were going to be able to talk to each other about this. Um, so, Amber, any other questions? Was that clear as mud? Do I need to clarify anything?
No, I think that it was pretty clear to me. It's actually interesting too when you think about it. You take those deep breaths to calm yourself down, and if a person is smoking, they're doing the exact same thing, but it's polluting their body. So,
Right, right.
yeah.
Mhm.
There are a couple of other questions that have popped up. Besides stopping to smoke, what type of treatment can doctors use to treat nicotine dependency?
Um, well, from you actually can treat it. I have some people who don't want to take nicotine replacement therapy products or use them, I should say. We call it NRT. That's your patch, your gum, and your lozenges, your inhalers. And some people, for whatever reason, don't want to take them, and then some people who have heart conditions or have had a heart attack within I think the 2 weeks of having a heart attack, you can't use them. So we used like vitamin therapy. Nicotine depletes, I think it's vitamin C, E, and D. So what I suggest a lot of times before people quit, that you build your body up by replacing those vitamins, um, in your body. Get into the habit of, if you can't walk outside, I do work with people who don't feel safe in their neighborhood, so they don't want to, walk around or whatever, but you can walk in your house or find some kind of physical activity. So my point is this: you don't always have to take medicines or whatever if you are willing to go from a holistic or wellness approach, but just know that usually it's going to take a little longer. Medicines and like the patch, which is what we call long acting, it takes about, I think, 2 hours to get into the system. So what we suggest is that you take the gum, and you don't, we call it gum, but don't chew it. It'd make you very sick. You just bite into it and you get a peppery taste, and then you park it between in your cheek. That's fast acting. So that helps with the cravings and the withdrawals. Doctors, I don't know if they want to take the time to share all that with you, because in terms of reimbursement, I think the reimbursement rate for physicians who or clinical providers who do tobacco cessation counseling, the most I've heard is $14. So, and that's like, I believe for 15 minutes. Don't quote me on that, but $14. And so, why would a doctor spend time talking to you about that if he's only going to make? I mean, it's the morally right thing to do, but doctors have bills to pay, and so a lot of times they opt not to address both or address it at all. So, to answer your question, there are natural ways to manage your cravings and the withdrawals.
Thank you. And we've got one last question. Coffee drinkers often complain about headaches if they don't have that cup of coffee in the morning. Are the
Mhm.
headaches caused by nicotine in caffeine?
You mean the combination of nicotine and caffeine?
If you could, Ambria,
Um,
can you unmute Ronald? And And please feel free to clarify your question there.
Hello.
Hi.
Hi.
Hi, Ronald.
I am a heavy coffee drinker, and I know if I don't have, my cup of coffee first thing in the morning, or if I skip it until noon, or skip it the entire day, I definitely have headaches and go through some sort of caffeine withdrawal. And
Mhm.
that's what I think it is. But I thought earlier, one of the earlier slides, it stated that caffeine there was a relationship between caffeine and nicotine. Is that my understanding? I think it was one of the earlier slides that.
Right. If you're a coffee drinker, so look at it like this, Ronald. So you're introducing caffeine into your body. You're also, if you smoke a cigarette while you're drinking coffee, you're introducing nicotine into your body. And if it's a Newport or a mentholated cigarette, now you're putting menthol. Now, menthol intensifies the action of nicotine and caffeine. But what you are describing, whether you smoked or not, some people are just sensitive to caffeine, such that when you don't get it, you have headaches and you don't feel well. Um, but it doesn't necessarily have to have anything to do with the cigarette. You just may be more sensitive to caffeine than some others. I am sensitive in another way. It gives me heart palpitations, and so I can't have uh, caffeinated drinks, period, whether that's coffee, sodas, or, anything with caffeine in it. Right away, my heart starts palpitating. Um, so I would not necessarily say that because your nicotine and caffeine is being combined, that that's why you're feeling like that, because you could feel that way if you weren't smoking.
Okay, because yeah, I'm not a smoker, but
Okay.
so I
Hmm.
thought, yeah, okay, I think I might have misunderstood that one bullet point.
Slide. Yeah.
Yeah. Okay.
Yeah, I apologize. I didn't mean to insinuate that, the combination. My point was that nicotine and caffeine are both psychoactive substances, but most people don't look at nicotine as a psychoactive substance. And so when people smoke, we kind of believe that they're smoking by choice. They should be able to quit by just not putting the product in their mouth or whatever. And my point is, for some psychoactive substances, we have rehab centers where people go to get help to, give it up. But I've only heard of, I think the Mayo Clinic may have a residential facility for people who are struggling to get over nicotine. We just don't look at it as the same. And so my point was, it is the same, but we have to, if we want people to stop, we have to treat it like a chronic relapsing condition and the psychoactive substance that it is. Make sense?
Thank you very much.
You're welcome.
Yes, thank you so much, Dr. Beard. At this time, did you have additional slides?
No, I think that was it. I just, my last, how to get in touch with us, our contact slide,
Perfect.
and
Perfect.
then just an invitation to everyone to reach out. If you have a question, everything's confidential, but I'd love to hear from you.
Wonderful. We did have a participant who has already left, but they are wondering about getting connected to the community engagement award funding opportunity that you mentioned.
Okay.
And so in follow up with you, if you could share that information with me and I'll make sure to get it into their hands.
Okay. And this is perfect timing. It's perfect timing. I think they're getting ready. There might be a waiting list, but they're getting ready for another round of awards. So great.
Wonderful. Thank you again so much, Dr. Beard.
Oh, thank you again for having me.
So at this time, I like to just give a little plug for the last few webinars of 2023 that the California Black Health Network is going to be hosting. Next week at 12 p.m. on Thursday, October 19th, we will be holding Brands, Beauty, and Breast Cancer. It will focus on the Non-Toxic Black Beauty Project in honor of Breast Cancer Awareness Month, which is this month. And then in November, our last webinar of the year will be held on November 9th at 12 p.m. It is session 5 of our Caregiving in the Black Community series. This is going to be focused all on navigating resources. So please feel free to visit our events page to register for those webinars that we've got coming up as part of our Health for Life initiative. And lastly, as usual, I like to share how you can get connected to us on social media. On Instagram and Facebook, you can find us at Your CBHN. On LinkedIn, you would be able to find us by typing in California Black Health Network. On the app formerly known as Twitter, we are at Your CBHN. And on YouTube, we are the California Black Health Network. Again, YouTube is where we host all of, I don't know if host is the right word, but where we store all of the recordings for previous Health for Life webinars, as well as our health equity forums. So next week, this webinar will be up on that YouTube channel, as well as all of the other sessions of the Control the Controllable series. So I want to thank everyone for joining us tonight. Thank you again, Dr. Beard, for sharing your expertise with us and putting together the presentation. I hope everyone has a great evening and take good care.